Assalamu alaikum dear students. Today we will be discussing the anatomy of the kidney under these heading: introduction, location, external feature, relations to the surrounding structure, covering that is capsule of the kidney, macroscopic structure, arterial supply, venous drainage, lymphatic drainage and nerve supply. Kidneys are two bean-shaped reddish-brown organs which lie in the abdominal cavity on the posterior abdominal wall. Their function is removal of the waste product of protein metabolism and excess of water and salt from the blood. So they maintain the water and electrolyte balance of the body and are crucial for survival. Kidneys are located on the posterior abdominal wall on either side of the vertebral column, behind the peritoneum, opposite the 12 thoracic vertebra and upper 3 lumbar vertebrae. They occupy the 4 regions of the abdomen, that is the hypochondriac, the epigastric, the umbilical and the lumbar regions. The right kidney is a bit lower than the left kidney because of the large right lobe of the liver. The long axis of the kidneys are slightly oblique, such that the upper pole of the kidneys are nearer to the midline as compared to the lower pole. If we measure the distance, the upper pole from the midlines are 2.5 cm, the hilum from the midline is 5 cm, and the lower pole from the midline is 7.5 cm. Also, the kidneys move downward in vertical direction for about 2.5 cm during respiration. This is the transpyloric plane. The transpyloric plane passes through the upper part of the hilum of the right kidney and the lower part of the hilum of the left kidney. Measurements and shape. The shape is bean-shaped. The length is 11 cm, the width is 6 cm, thickness is 3 cm, and weighs in males 150 gram and in female 135 gram. External features. Each kidney presents the following external features: the 2 poles, the upper pole and the lower pole, the 2 surfaces, anterior surface and posterior surface, and the 2 border, the lateral border and the medial border. The middle border present a vertical slit called hilum. Now coming to the pole, the superior or upper pole is thick and rounded and is nearer to the midline as compared to the lower pole, and it is related to the suprarenal gland. The inferior pole is thin and pointed and lies 2.5 cm above the iliac crest. This anterior surface is convex and the posterior surface is flat, but we cannot differentiate from anterior surface from the posterior surface practically. Practically, we identify the anterior and posterior surface from the arrangement of the structure at the hilum. The most anterior is the renal vein, then is the renal artery, and then is the pelvis of the ureter. The borders. The medial border of the kidney is convex near the upper part near the poles and convex at the lower part near the pole, and in the middle it presents a vertical fissure called hilum, which has anterior and posterior lips. The lateral border of the kidney is convex. The medial part in its central area shows a deep vertical slit called hilum, which transmit from before backwards. The most anterior is the renal vein, then the renal artery, then the pelvis, and then the subsidiary branch of the renal artery. In addition to these structures, the hilum also transmits lymphatics and nerves. Relations of the kidneys. The anterior relation of both the kidneys are different, but the posterior relation of the kidneys is almost the same. The anterior relation of the right kidney and anterior relation of the left kidney. So the common relations are that the upper pole of the right kidney and that of the left kidney is related to suprarenal gland. So this is the suprarenal gland related area, so called the suprarenal area. Then comes the area of the right kidney and the left kidney, which is related to the colon. Here the hepatic or right flexure of the colon, and here is the left or splenic flexure of the colon. This part on both sides is related to the jejunum. So the common is suprarenal gland, the colon, and the jejunum. On the right side is the right lobe of the liver, so it is related to the right kidney is related to the right lobe of the liver and the second part of the duodenum. The right kidney is also related to the second part of the duodenum. On the left side there is stomach, so the left kidney is related to stomach. Also it's related to the spleen because on the left side spleen is present, and this area is related to pancreas. On the right side, the liver and jejunum are separated from the kidney by peritoneum. There is peritoneum between the right kidney and the liver and jejunum. On the left side, stomach, spleen and jejunum are separated from the kidney by peritoneum. So in between these and the kidney is peritoneum. Coming to the posterior relations of the kidneys, the posterior relation of the two kidneys is almost the same, except that the right kidney is related to one rib and the left kidney is related to two ribs. Both the kidneys are related to these structures, the four muscles, that is the diaphragm on either side, then the pons major muscle on either side, then the quadratus lumborum muscle on either kidneys, and this is the transversus abdominis. So both the kidneys are related to four muscles: diaphragm, pons major, quadratus lumborum and transversus abdominis, and three nerves, that is the subcostal nerve and vessels, that is the iliohypogastric and ilioinguinal nerve, and same on this side. So both kidneys are related to three nerves. The subcostal nerve is accompanied by the subcostal vessels. The right kidney is related to 12th rib only, and the left kidney is related to 11th and 12th ribs. So these are the posterior relation of the kidneys, the difference being only the right kidney is related to 12th rib and the left kidney is related to 11th rib also. This is the right kidney, a bit lower than the left kidney. This is the pons major muscle, this is the quadratus lumborum muscle, and this is the transversus abdominis muscle, and this is the diaphragm. So posteriorly it is related to diaphragm, the pons major muscle, the quadratus lumborum muscle, and the transversus abdominis muscle. Capsule or covering of the kidney. From within outward, the kidney is surrounded by four coverings. The innermost is the fibrous capsule or true capsule. This one is the fibrous capsule, the innermost. The fibrous capsule, renal capsule are the true capsule. This is the innermost one. Then comes the perirenal fat. This yellow area, this is the perirenal fat. The third one is the renal fascia or false capsule. This is the renal fascia or false capsule. This is also called the fascia of Gerota. The fourth one is the pararenal fat. This is the fourth layer, the pararenal or paranephric fat. So these are the four layers. The innermost, the fibrous capsule, the perinephric fat, the renal fascia, and the paranephric fat. The paranephric fat, the renal fascia, and the perinephric fat support the kidney and hold them in position on the posterior abdominal wall. First we will discuss the fibrous capsule or true capsule. It is a thin membrane which closely invests the kidney. It is very closely applied to the kidney. It is formed by condensation of the fibrous connective tissue. It can be easily stripped off or removed from a normal kidney, but when the kidney is inflamed, it becomes firmly adherent to the kidney and it cannot be removed from the kidney. Coming to the second layer, that is the perinephric fat. This layer, the perinephric fat. So the perinephric fat is present between the true capsule, the fibrous capsule, and the renal fascia. The renal fascia is very loosely applied, and in between them is the perinephric fat. It fills the space within the renal fascia, between the renal fascia and the fibrous capsule. It fills this space. And these perinephric fat also is prolonged through the hilum into the renal sinus. In chronic diseases, when there is depletion of the perinephric fat, so what happens then, the kidney inside this renal fascia becomes loose and it can move downward. So this will lead to kinking of the ureter. So in chronic debilitating conditions, when there is depletion of the perinephric fat, there is downward displacement of the kidney, which leads to kinking of the ureter. Renal fascia false capsules are fascia of Gerota. The renal fascia, this surrounds the kidney and the perinephric fat. The one in green is renal fascia. The renal fascia is a fibroalveolar sheath which surround the perinephric fat. This is the posterior aspect of the chest, the posterior abdominal wall with quadratus lumborum. So the renal fascia has two layers, the anterior layer and the posterior layer. We will study its superior extension, inferior extension, the medial extension and the lateral extension. Superiorly, the two layers of the renal fascia enclose the suprarenal gland in a separate compartment and fuse with each other and become continuous with the diaphragmatic fascia, rather suspending it from the diaphragmatic fascia. Inferiorly, after enclosing the kidney, the two layers remain separate and encloses the ureter. This is the anterior layer, posterior layer. Inferiorly, they remain separate and encloses the ureter. The medial and lateral extension can be studied in this transverse section of the kidney. This is the kidney. This is the anterior layer of the renal fascia. This is the posterior layer of the renal fascia. Laterally, these two layers, anterior layer and posterior layer, combine with each other and then combine with the fascia transversalis. Medially, the anterior layer passes in front of the kidney, the renal vessels, and then merges with the connective tissue surrounding the inferior vena cava and aorta. This is the quadratus lumborum muscle, fascia over the quadratus lumborum muscle, and this is the psoas major muscle and its fascia. The posterior layer of the renal fascia passes between the kidney and the fascia of the quadratus lumborum muscle and then combine with the fascia of the psoas major muscle. So this is the superior, inferior, medial and lateral extension of the renal fascia. The fourth layer is the pararenal fat. It is present outside the renal fascia. It is present on the posterior aspect of the kidney and is more abundant near the lower pole of the kidney. It fills the paravertebral gutter and it acts as a cushion for the kidney and prevents the kidney from injury. So the final layer is the layer of the pararenal or paranephric fat. Macroscopic structure of the kidney. If we divide kidney longitudinally, we can see two distinct regions. One is this region called the kidney proper, and one is this region called the renal sinus. So the kidney can be divided into renal kidney proper and the renal sinus. The kidney proper in turn can be divided into cortex. This is the cortex and this is the medulla. So the kidney proper can be divided into cortex and medulla. The cortex is the area of the kidney proper which lies just beneath the renal capsule. Beneath the renal capsule immediately is the renal cortex. This is the renal cortex. The renal cortex also extends into the medulla between the renal pyramids, and these extension is called renal column. So these are renal columns. These are extension of the cortex of the kidney. This is the medulla. The medulla consists of 5 to 11 dark conical masses called renal pyramids. This is one renal pyramid, this is another renal pyramid, and so on. A renal pyramid has a base and an apex. The apex of the renal pyramid form nipple-like projections called renal papilla. These renal papilla project into the minor calyx. This renal pyramid plus the overlying cortex form the part of the kidney called lobe of the kidney. So this is one lobe of the kidney, this is another lobe of the kidney, and another lobe of the kidney. Renal sinus is a cavity present inside the kidney, and this renal sinus open at the medial border as the hilus. This is the ureter, this is the pelvis of the ureter, this is the major calyx, this is the another major calyx, this is the minor calyx, another minor calyx, minor calyces. So the greater part of the renal pelvis, the major calyces and the minor calyces lies within the renal sinus. The renal vessels, lymphatics and nerves and perirenal fats also lies here. We know that the perirenal fat also follows the sinus. The renal pelvis within the renal sinus divides into 2 to 3 large branches called major calyces, and each major calyx divides into short branches called minor calyces. The minor calyces are 5 to 11 in number. Each minor calyx at its end expands and is indented by the renal papilla and molds around the renal papilla. The collecting tubules in the renal papilla first perforate the renal capsule, then the wall of the minor calyx, and then open into the minor calyx. We know the renal capsule lines the kidney as well as the sinus. So the renal tubule, before entering the minor calyx, they have to perforate the renal capsule and then the wall of the minor calyx. In this way, the pelvis of the kidney is connected to the tissues of the kidney, to the tissue of the kidney by calyces. The kidneys are supplied by renal artery. The renal arteries enter through the hilum of the kidney, but at times they may enter the poles of the kidney, especially the lower poles. One renal artery for each kidney, but at times there may be present accessory renal artery in 30% of cases. The renal arteries rise just below the origin of the superior mesenteric artery at the level of the disc between L1 and L2 vertebra. The right renal artery, after its origin, passes behind the inferior vena cava and the right renal vein and enters the hilum of the right kidney. The left renal artery, after its origin, passes behind the left renal vein and enters the hilum of the left kidney. This is the anterior aspect of the kidney. This is the posterior aspect of the kidney. The renal artery at or near the hilum divides into an anterior division and a posterior division. This is anterior division, this is the posterior divisions. The anterior and posterior division in turn divide into segmental arteries. These are called segmental arteries because they supply a particular segment of the kidney. This is the apex of the kidney, so this is the apical segment on the anterior aspect and posterior aspect. This is the upper segment on the anterior and posterior aspect. This is the middle segment on the anterior and posterior aspect, and this is the lower segment on the anterior and posterior aspect, and this is the posterior segment. So the anterior division gives rise to segmental arteries which supplies the four segments of the kidney: the apical, the upper, the middle and the lower. And the posterior division gives rise to segmental arteries which supply only one segment, that is the posterior segment of the kidney. So there are in total 5 vascular segments of the kidney: the apical, the upper, the middle, the lower and the posterior segment of the kidney. These segmental arteries, after supplying the renal sinus, they divide into lobar arteries. The lobar arteries in turn divide to form the interlobar arteries. This is the lobe of the kidney. We have already said that the renal pyramid with the overlying cortex is called the lobe of the kidney. So it passes between the two lobes of the kidney, so it is interlobar artery. So in medulla, the lobe of the kidney is demarcated and is between the two interlobar arteries, while in cortex its limits are ill-defined. At the junction of the medulla and cortex, the interlobar artery divides dichotomously into arcuate arteries. These are the arcuate arteries. The arcuate arteries in turn give rise to interlobular arteries. So a lobule will be in the cortex, will be in between the two interlobular arteries, but the part of the lobule in the medulla is not defined. Here it can be limited by the two interlobular artery, but in the medulla it is not well defined. The interlobular artery gives rise to afferent arteriole, which split to form the glomerular capillaries, and these capillaries unite to form the efferent arteriole. The efferent arterioles give rise to again the peritubular capillary fluxes and vasa recta, and these in turn drain into interlobular veins. The interlobular veins in turn drain into the arcuate veins, then the interlobar veins, the lobar veins, and ultimately into the renal vein. If we look at the arcuate arteries, these are the arcuate arteries, the red and the blue one. So this is the arcuate arteries, this is the arcuate vein. So the arcuate artery gives rise to interlobular artery. The interlobular artery gives rise to afferent arteriole. The afferent arterioles form the glomerular capillary network, then the efferent arteriole, the peritubular capillary network, and the vasa recta, and these then combine to form the interlobular vein, and the interlobular vein drains into arcuate vein, and the arcuate veins draining into interlobar veins, and the interlobar veins into lobar veins, and ultimately into the renal vein. This is the renal artery, its anterior and posterior division, and the segmental arteries. This is the anterior aspect of the kidney, posterior aspect of the kidney, and lateral aspect of the kidney. So Graves, on the basis of distribution of major branches of the renal artery, divide the kidney into 5 segments. These are called vascular segments: the apical, the upper, the middle, the lower, and posterior segment. This segmental supply is very important because there is no anastomosis between these segmental arteries. As there is no anastomosis between these segmental arteries, so if there is disease of a particular segment, we can only remove that particular segment along with its blood supply. So it is very important. Localized excision of the kidney is possible on the basis of this vascular segment. The venous drainage of the kidney is through renal veins. There are 2 renal veins, the left renal vein and the right renal vein. The left renal vein, after its formation at the hilum of the kidney, passes in front of the left renal artery and then crosses the aorta just below the origin of the superior mesenteric artery and enters the inferior vena cava, while the right renal vein, after its formation at the hilum of the right kidney, passes in front of the right renal artery and joins the inferior vena cava. The lymphatic drainage of the kidney is to the para-aortic lymph nodes, which are present near the origin of the renal arteries. The nerve supply of the kidney is through renal fluxes, which reach the kidney through the renal arteries. The renal fluxes are formed from both sympathetic and parasympathetic fibers. The sympathetic fibers are derived from T10 to L1 spinal segments, T10 to L1 spinal segments, and the parasympathetic fibers are derived from both vagi. Clinical correlation: 1 is lobulated kidney. Fetal kidney has lobules, and these lobules may persist in adult kidney. It has no clinical significance. Another is the aberrant artery. Persistence of one of the fetal artery is common, and that occurs in 30% of the individuals, especially an artery from aorta to the lower pole of the kidney. So a surgeon, while performing nephrectomy, he should keep in mind the presence of aberrant artery. He should rule out the presence of aberrant artery. Another condition is congenital polycystic kidney. It is the presence of multiple cysts in the kidney. It occurs because the luminal continuity between the nephrons and the collecting tubules fails to establish. That is, the nephrons and the collecting tubules do not join. If the nephrons are forming urine, it cannot be excreted because there is no continuity between nephron and collecting tubules. So this urine will accumulate and form cysts. These are multiple cysts in the kidney called congenital polycystic kidneys, and these are also called retention cysts. Another is the horseshoe kidney. The lower poles of both the kidney may unite to form a horseshoe-shaped kidney. This fused area is called the isthmus of the kidney. The ureters passes in front of the isthmus of the kidney, and the inferior mesenteric artery also passes in front of the isthmus of the kidney. So this inferior mesenteric artery limits the ascent of the kidneys. Renal agenesis: if the ureteric bud fails to develop, kidney will not form. And unilateral renal agenesis is quite common. That is, absence of kidney on one side is common. So the physician must not assume that the patient has 2 kidneys, and a surgeon must confirm that the patient has 2 kidneys before removing the kidney, that is, before going nephrectomy. Renal pain is pain felt in the line, and it may radiate downward into the groin. The renal pain varies in nature from dull ache to severe spasmodic pain, and the renal pain occurs due to stretching of the renal capsule or spasm of the smooth muscles of the renal pelvis. Renal angle is the angle between the lower border of the 12th rib and the lateral border of the erector spinae muscle. The renal angle is the area where the pain of the kidney is felt. Usually the pain of the kidney is felt area as dull ache, but in case of perinephric abscess, this area is very tender. In case of enlargement of the kidney, this area, the area of the renal angle, become full. So with this we finish the anatomy of the kidney, and next time we will be studying the ureter and urinary bladder. Until then, Allah Hafiz.